I now have the distinct pleasure of introducing Dr. Brian Smedley. Dr. Smedley is among the inaugural class of the Equity Scholars at the Urban Institute, where he will conduct research and policy analysis to address structural and institutional forms of racism that impact the health and well-being of people of color. Formerly, Dr. Smedley was Chief of Psychology in the Public Interest at the American Psychological Association, where he led APA's efforts to apply the science and practice of psychology to the fundamental problems of human welfare and social justice. A national thought leader in the field of health equity, Dr. Smedley has extensive experience in policy and research. He has directed studies and reports for the Institute of Medicine on diversity in the healthcare workforce, racial and ethnic disparities in healthcare, among other reports on diversity in the health professions and minority health research policy. Most recently, he was co-founder and executive director of the National Collaborative for Health Equity, a project that connects research, policy analysis, and communications with the on-the-ground activism, which Congresswoman Kelly just spoke about, to advance health equity. Dr. Smedley received a PhD in clinical psychology from the UCLA in 1992 and a BA degree in psychology and social relations from Harvard University in 1986. Without further ado, Dr. Brian Smedley.
Well, good morning. I am so delighted to be here. I want to thank the co-conveners of this important meeting. What's exciting coming here today is that we have groups that almost never come into the same room together. We have leaders in academia, government, civic groups, consumer groups, and the private sector. And the reason why that's important is because we all have a role to play, importantly, in tackling racism in the healthcare sector. And in fact, I would submit that no one sector alone is going to be able to tackle these challenges. I think we all recognize that. So truly, my thanks to the conveners of this important event. I want to thank Naisha Foster. Melissa, thank you so much for that warm introduction. We have work to do. And what I'm most excited about are the last two words in the title of this program, Health Equity in Action, because hopefully that will be us as we leave here today. This is not an opportunity just to hear folks talking, not an opportunity to hear yourself wax eloquently about the problems of racism, or me or anybody else. We're here to figure out how we solve these problems. So for me, the first challenge when we're talking about racism is elevating what is often invisible, helping people to understand what we take for granted every day and fail to recognize as forms of racism. Most folks in the US still think of racism as a bad apple problem, somebody with a hood over their head, harboring racial animus, and of course that persists, and we see that in spades, in abundance these days. But it's the less visible forms of racism that we need to be very, very clear about, and to elevate how those create conditions in which people of color suffer poor health. So let me just dive right in and start by acknowledging and thanking the dozens, hundreds of governmental entities across the country that have declared racism a public health crisis. We see local governments, state governments, even our own CDC here in Atlanta declaring that racism is a public health crisis. And we have abundant evidence, of course, that this problem persists. In the effort to lift up and understand and to illustrate how racism operates, and particularly in ways that go beyond individual intent, we need to understand structural and institutional forms of racism. Structural forms of racism, of course, are those interlocking systems, policies, practices, cultural narratives that create conditions for poor health for people of color. It allocates resources inequitably based on a white supremacist myth that people of color cannot benefit from those resources. And so structural forms of racism include things like residential segregation, which I agree with Dr. David Williams, sets the stage, is foundational to the racial and ethnic health inequities that we see here in the US, particularly in the black-white context. And so residential segregation, of course, is a form of structural racism because many entities collaborated to create segregated communities throughout most of American history. We have governmental entities, private sector actors, all colluding to create separate spaces. And of course, the consequence of that is the concentration of poverty in communities of color and a heavy concentration of health risks. We all know what those risks are: sources of air, water, and soil pollution, food deserts, a lack of geographic access to healthcare services. These are all consequences of residential segregation. Institutional forms of racism include policies and practices that are neutral with respect to race on their face, but nonetheless result in negative racialized outcomes. Think about policies that many law enforcement agencies still practice to this day, so-called stop and frisk. We know from piles of research that stop and frisk policies target Black and brown young men and result disproportionately in damage to their well-being, their sense of security, their health, even their educational opportunities. So these are policies that are neutral with respect to race, but nonetheless have a negative racial intent. So these are examples of racism in operation that damage our health. And it's our responsibility to begin to elevate those forms of racism. A quote that I really like, and some of you may have heard this quote before, Kareem Abdul-Jabbar, Hall of Fame basketball player, also a very smart man, said, "Racism is like dust in the air. You don't see it until you shine sunlight on it." And that's part of our job, to shine that sunlight on those forms of racism. I also don't need to tell you that we've made little progress in the last couple of decades toward eliminating racial and ethnic healthcare inequities. These are data from the Agency for Healthcare Research and Quality, the annual Healthcare Quality and Disparities Report. Each year they've put out this report documenting the magnitude of racial and ethnic gaps in the quality of care as well as access to healthcare services. And what they've found over the past 20 years is that overall the quality of care in America is improving, but those racial and ethnic gaps remain stubborn. As you can see from this slide here, for populations of color relative to the white population, on a number of measures that AHRQ uses to measure quality of care, we find that for the vast majority of indicators, these measures are either the same as for white patients or worse. And so this stubborn gap has remained over the last 2 decades, even despite our knowledge, our increased awareness of the fact that these inequities exist. There are many, many factors that are associated with healthcare inequities. It is a mistake to try to simplify the problem because there are many factors, many forces that help to contribute to these inequities. I want to lift up 5 of these sources of inequity because they are among the issues that we'll be talking about today and trying to find solutions for. So, separate and inequitable healthcare systems, a form of structural racism in our healthcare systems in itself. Due to many factors, residential segregation, the maldistribution of healthcare resources, healthcare system policies such as limited provider networks. These are all among the factors that create separate and unequal healthcare, and I'll say a little bit more about that. We also continue to have tiered health insurance and differences in provider reimbursement that are tremendously significant and racialized because of the populations that are insured by our various public and private sector insurance offerings. So we need to begin to explore that, and we'll examine that as well today. Clinician biases, stereotypes, and prejudice. We've got a large and growing body of research on this issue. How does race infect the clinical encounter? And of course, we need to begin to uncover strategies to de-bias our providers and help them to be better prepared to treat a very diverse patient population. Increasingly, we see challenges with race-based clinical decision support and algorithms. Machine learning, artificial intelligence is here to stay as a clinical decision support, but unfortunately, those sources of machine learning have great potential to replicate inequality because of the sources of data that are used to input into those algorithms. So we need to be very aware of the potential of these tools to cause harm, even as we are attempting to support clinicians in their decision making. And then finally, I would argue that a persistent lack of diversity among healthcare professionals, again, remains a stubborn problem, again, emerging from racism, and particularly the structural forms of racism that infect our educational systems, creating inequitable opportunities to prepare for a career in health profession. So I want to examine each of these in a little bit more detail in an attempt to begin to set up our conversation today. First, separate and unequal care, what some have referred to as medical apartheid. We still see that patients of color are largely treated in systems that are poorly prepared to deal with the challenges that these patients are bringing into the door. My colleague, Anuj Gangopadhyay at the Urban Institute has studied the differences in black and white patient safety measures using hospital discharge records from over half of our states. This research team that found that for 80% of the patient safety measures, black patients were significantly less likely to be admitted into hospitals classified as high quality, again, contributing to this problem of separate and inequitable care. The same team found that black patients experience higher rates of hospital-acquired infections or injuries related to surgical procedures relative to white patients in the same hospital. So we have both differences, racial and ethnic differences in patient safety between hospitals and also within hospitals. That illustrates the depth of the problem of racism that we have both within our healthcare systems and across these various systems. Looking at the problem of tiered health insurance, I was so honored 2 decades ago to serve as study director for the IOM Unequal Treatment Report. That report noted that a big part of the challenge with providing quality care, equal quality care for all patients, is the fact that we have tiered health insurance. We all know this, not all health insurance is alike. And the Unequal Treatment Report noted that medical care financial arrangements should discourage fragmentation of healthcare provision into separate tiers of providers who adhere to different standards of care. That's true today when we look at how our Medicaid reimbursement fails Medicaid patients relative to private pay patients. The problem of racial bias among providers, again, persists. Striking to me to this day to see evidence that providers harbor mistaken assumptions, stereotypes, and biases, both explicit and implicit, that may infect their clinical decision making. One review of 15 studies measuring implicit bias in health outcomes confirmed that healthcare professionals hold the same level of implicit bias against Black, Latinx, and dark-skinned people as the general population. The vast majority of the US population harbors pro-white implicit biases, right? Implicit biases measure the speed of your ability to make an association between a word and an image. And in this case, the vast majority of people socialized in the United States have a harder time making an association between a black face and a positive word versus a white face and a positive word, and so on. And so those biases persist largely throughout society, and it is unrealistic to expect our healthcare providers are somehow insulated from that socialization. Another study, a review of 37 studies, confirmed the substantial evidence of pro-white or light-skinned, anti-black, Hispanic, American Indian, or dark-skinned bias among a variety of healthcare professionals. Here's a study that continues to stun me. Over 70% of white medical students in a recent study believe that there are biological differences in pain perception between blacks and whites. Stunning, right? And you still see that playing out today in terms of differences in pain treatment. And we also have evidence that in patient medical records that black patients more frequently receive negative comments from the provider in their patient records. In fact, over 2.5 times more likely to have negative comments in those patient records, including the use of words like refused or not adherent, not compliant, agitated, etc. So you can see biases playing out in real time in the use of in these records. Artificial intelligence, machine learning, clinical decision supports. Again, machine learning is here to stay, but used properly, it can assist clinicians. Used improperly, we are finding evidence that it can replicate racial inequality. The House Ways and Means Committee in a staff report a couple of years ago found that the methods and assumptions used in the algorithms at the core of clinical decision support tools may themselves import biases that are detrimental to people of color. So as the old saying goes, garbage in, garbage out. We need to be very careful about how those tools are used. Finally, the lack of diversity among the healthcare provider workforce in this country remains a problem, and has been so for decades, generations, of course. As you can see from this pie chart, the distribution of all active physicians is on the left. The distribution of the U.S. population is on the right. We need to ensure that our provider workforce looks more like the U.S. population to be able to overcome cultural, linguistic barriers and to overcome issues of trust and mistrust. And indeed, our institutions will not be trustworthy until we tackle this challenge of improving the diversity of the workforce. I mentioned the IOM Unequal Treatment Report. Another report that I was very proud to be associated with was this report from 2005, In the Nation's Compelling Interest, Ensuring Diversity in the Healthcare Workforce. This report looked at the policies and practices in particular of health professions education institutions to understand what can they do to ensure that we have a steady pipeline of talented young people of color coming into these professions. This report encouraged changes in health professions education admissions, including whole file review, de-emphasizing standardized tests. These recommendations couldn't be more important with the Supreme Court reviewing and likely to dismantle affirmative action programs in higher education. We need to go further to attend to the institutional racial climate. It's one thing to admit talented students of color into our medical schools and nursing schools, but if they come into a hostile institution, then we have wiped out all of our efforts to ensure that we are bringing talented people into these institutions. We need to attend to diversity standards in our accreditation. It is no longer acceptable to offer accreditation if institutions fail to advance the cause of diversity in health professions. And we need to remove financial barriers for students who wish to work in underserved communities. The U.S. Public Health Service programs have been enormously successful in getting providers working in underserved communities, and with that payback agreement, many stay in those communities to provide services. Ultimately, though, we've got to fix educational inequity, racialized educational inequity directly tied to structural forms of racism with separate and unequal educational systems funded inequitably primarily by local tax dollars. This is a form of structural racism that we've got to tackle and confront. There's no one individual with animus behind those policies, but those of us who recognize the critical importance of health and advancing health equity understand that that is part of our challenge as well. So today, we are here for action. We're going to roll up our sleeves and work on several of these topics: research and data, workforce, policy issues, particularly as they pertain to reimbursement, and healthcare facility and healthcare delivery. All of these issues are among the important issues where racism infects our ability to provide high quality care for all patients. I want to conclude with a quote I like from Dr. Mary Bassett, who has been such an inspiration to many of us, who leads the Department of Health in New York State. Some years ago, she wrote that anti-racism is a collective healing without which our nation will remain painfully and inequitably divided, corroding opportunity, spirits, and bodies alike. And it's our challenge to make sure that we undo that racism at the core of this challenge. Thank you so much.